another week on our international rounds. And this week is actually it's my great pleasure always to present the presenter, but this week is a particular personal touch. Dr. Wei Li, who is the director of the Congenital Echo Lab in London, but also is my mentor, and is the person that taught me almost everything I know about echo and congenital heart disease. So it's a great pleasure to have you here, Wei, and the floor is yours.
Thank you, Rafa. It's very kind of you to invite me. I'm really honored and to give this talk. I hope everybody should enjoy the time. It's nothing difficult. We're just all learning together. So today, Rafa wants me to talk especially about assessment of complex congenital heart disease. I know for the patient, for the people don't know congenital heart disease, so every single congenital heart disease will be difficult, will be complex, but the fact is not always true like that. So, oh, sorry. So in congenital heart lesions, there is a great variation of anatomic lesions, and the majority patients will have undergone previous palliative or reparative surgery. Some have multiple. This makes things complex. And many have residual lesions and complications, and some of these lesions we cannot imagine until we see it. We cannot believe it until really we diagnose them. So the patient will face gradual hemodynamic deterioration, onset of arrhythmia, increased risk of heart failure. For us, doing the assessment with echo, we have to assess all these anatomical, hemodynamic, and the residual lesions and the cause for the arrhythmia and also clinical deterioration. So the job is heavy. This is why it's not very easy. So ACHD is relatively new subspecialty. If you see echo in SHD, it's really a new subspecialty. For us, there is no established guidelines there to use yet. So this is why we have published this consensus recommendation for echo in ACHD with the ISEC together. Of course, this was composed with people representing multiple established center. Toronto, you can see Owen is one representative. We have summarized all our experience. In this consensus paper, we have given general guidelines, and also we have affiliated about 13 very detailed protocols for each lesion. I think this is intention to make our echo studies uniformization and to improve the quality of our assessment. So in general, when we want to do the congenital echoes, we must have the knowledge of medical history, previous intervention, and operation notes. We should read it before we start. And we must be aware there are non-conventional views or in-between views we often need it, because in our congenital patients, the heart can be located anywhere, and surgically created structures can be very difficult to identify. So echo probe, just use it as a torch. Scan wherever you think there will be the structure you want to locate. So in order to make things easier, simpler, we should follow the sequential segmental analysis in every single complex cases. Here, I'm just giving you some examples.
Yes, babies growing, and if they're, if they're concerned, they might increase up the frequency of those scans. But
can you please mute your microphones?
From my point of view, that they need to, unless they detect an issue. I suppose, you know, it would be very unlikely that that issue is related to the medication.
Sorry.
It's just on this scan, you see on the left, this is obviously echo from a normal patient. You can see the structure on the left.
Yeah, sure.
Left atrium and left ventricle.
Post-traumatic prescription.
And we will pass easily. This is a normal heart. But on the right hand side, these patients come to us with also a diagnosis of normal structure. But if we know the structure by their morphology, we know this is not normal. Why? We can see from the left, we have obviously reversed the setting. We have more apically displaced AV valve. We have more trabeculated ventricle on the left side. So this is a morphological right ventricle, but on the left position. The core of the sequential segmental analysis is morphology. So we should describe all the chambers, all the great artery and valve by their morphology, not by their position. So in that way, we don't get ourselves confused. Here is another example. Here's the patient. If we don't look at sequential arrangement, we will totally get confused. Actually, this patient come to us, really everybody is scratching their head to see what is this diagnosis. You see on the left, supposed to be the left atrium, but we can see a structure which is a pacing Y in the left-sided atrium. So we're sure we don't normally put pacing Y in the left atrium. So we go back to look at the situs on the right-hand side. You can see this patient actually have a situs inversus. That means the aorta is on the right and IVC on the left. In this case, the atrium arrangement should be reversed. So on the left should have a right atrium, but this right atrium are connected to a morphologically looking left ventricle. They have less displaced AV valve and much smoother. And you can see this patient had a conduit created from apical area connected to the pulmonary artery. So sequential analysis suggesting for us, this patient have situs inversus with AV and VA discordance and also kind of CCTGA. But if we describe in detail, then for people, it's much easier to understand. So by the end of the day, I would say we should go back to basics, especially when we are facing a complex patient. We know in general, heart was composed of 3 segments, atrial, ventricle, and great arteries. And there is 2 connections, atrial ventricular and ventricular great arteries. In congenital malformation, all the segments and the 2 connections can be abnormal. But if we go step by step from basic atrial arrangement to the great artery, then we can describe it in detail and for everybody to understand. So this is a summary how we do the segmental analysis. First, I would suggest we should identify the heart location, whether the heart in the left chest or right chest, so you know you don't put your probe on the left if the patient have a dextrocardia. Then followed by identify the arrangement of atrial chamber. Then we have to assess the atrioventricular junction, identify the ventricular morphology. Finally, we will assess the ventricular-arterial connections. Then at the end, we should assess the additional lesions, namely a septal defect, ASD, VSD, and the valve dysfunction. So I don't want to frighten everybody away. Here, I just want to show you in our daily life what kind of patient we're facing. Here's the data published in 2015, about 7,000 patients we followed here. You can see most of these patients have simple lesions. Most common is ASD. If we counted follow as simple because after repair, they have biventricular heart with AVVA concordant after repair. So we see complex, including transposition, systemic RV, more complex like isomerisms. This, we have possibly about 15 to 20% complex lesions in our population. So that is not a lot, but we have to assess them very carefully. Here, I just show how the echo can help us to do this assessment. So we start with the location of the heart. That can be easily identified by scanning from subcostal view. From subcostal view, we can see whether the heart in the left side of chest with apex towards left, or heart in the right side of chest with apex pointing towards the right. Then followed by the atrial arrangement. So in theory, we know there is 4 possibilities of the atrial arrangement. Usual, that is possibly in 99% of our population. And we have mirror imaging, which is the opposite of normal. Then we have a group with isomerism atrial arrangement, either left or right. This is also a part of a heterotaxia syndrome, usually associated with other organ abnormalities as well. So the identifiable anatomical feature of atrium is its appendage, but in adults, it's very hard on echo to see the appendage clearly. We have to use the indirect side. That means the arrangement of great vessels from the subcostal view we can scan. Normal, we have aorta on the left, IVC on the right. This corresponding to the uroatrial arrangement. If it's opposite of this uro, we get mirror imaging. So we get IVC on the left. Normally, we will have a right, morphological right atrium on the left. So problem comes when there is great vessels on same side of the spine, either on the left or on the right. This is in about 60 to 70% of these patients will have isomerism atrial arrangement, either a right atrium isomerism when the IVC anterior or aorta is anterior, you're more likely to see left atrium isomerism. This, especially right atrium isomerism, usually associated with complex intracardiac anatomy. So when we have learned about atrial arrangement, we are going to decide about atrioventricular junction. But before that, we must know how to recognize the anatomic features of the ventricle. We know left ventricle have much fine trabeculation. They are guided. It was guided by the mitral valve without septal attachment. On the echo, mitral valve is a valve less displaced towards apex from 4-chamber view. So that is very helpful markers of identifying left ventricle. But right ventricle, we all know, have much coarse apical trabeculation and guided by tricuspid valve. They are more displaced towards apex on the 4-chamber view with septal attachment of the AV valve. So there is a small group of patients who have a univentricular atrioventricular connection. So I will talk about this in more detail. Once we diagnose the atrioventricular connection, we are going to the ventricular-arterial connection. Again, we must recognize the great vessels by their anatomical features. We say the aorta will give rise to the coronary artery and head neck vessels and vessels to the body. Pulmonary artery normally bifurcate into left and right pulmonary artery. Common arterial trunk. So it's like aorta. In addition, they also gave intrapericardial pulmonary artery. Then if we cannot find the main pulmonary artery, then we will think there is absence, we will call this solitary arterial trunk. Normally, the pulmonary artery will be supplied by the collateral vessels arising from the descending aorta. And now the classic example of ventricular arterial discordance is like this, is transposition, we normally call it, classic transposition. So here from parasternal view, there is the echo features. So great vessel lost their spiral relationship. They become a parallel. And we look carefully, the vessel behind the more posterior is bifurcating. So that is very simple, easy to recognize. This is a pulmonary artery. Then we can assume anterior vessel is aorta. So we say this is a classic transposition. We all know without additional lesion or additional communication in the heart, this patient normally cannot survive. They have to have pre-existing atrial septal communication or ductus. But in adults, they will come. Most of our old patients will have an intra-atrial redirection surgery that is mastered or sending operation. I think being the home of the mastered in Toronto, you must have a lot of mastered patients. So they have redirected at atrial level, the surgical baffle put to guide the pulmonary venous flow to the right side and going to the morphological right ventricle, then pumped into aorta. Then similar way, the systemic venous return will be guided towards the right side, morphological LV, and pumped to the pulmonary artery. Although the hemodynamic flow has been corrected, but anatomic abnormalities are still here. In them, we have a morphological RV is supporting the systemic circulation. So this disadvantage of systemic RV has been overcome by the surgical operation of arterial switch operation. This happened after 80s. I think more younger patients will have arterial switch operation, but it is not without complication. We are starting seeing more and more complications in them. If the patient born with a pulmonary stenosis or ventricular outflow tract obstruction, it cannot have an arterial switch. Most of the patients will have a Rastelli type of repair with surgical conduit being put from ventricle to pulmonary artery. With the mastered operation, I think you have seen a lot. We know there are a lot of late complications, namely tricuspid valve regurgitation, venous baffle obstruction or baffle leak, pulmonary hypertension. Most of them is pulmonary venous hypertension. A small percentage of them will have severe pulmonary arterial hypertension, residual VSD, and again, systemic RV dysfunction is possibly unavoidable, the final complications of this group of patients. So how are we assessing this? We must know why they have this complication. For severe tricuspid valve regurgitation in them, usually it's a late complication and subsequent of ventricular dysfunction. Often we say the valve will be tethered and annulus is dilated. Very rarely they have Epstein-like abnormalities. Severe tricuspid valve regurgitation is not a good sign for this kind of patient. They are associated with decreased survival. So in another group of patients, the morphological RV supporting systemic circulation is so-called congenitally corrected transposition, like here. On the left side, we have a morphological right ventricle. We can identify it because they were guided by the tricuspid valve. This patient actually have quadracusps, but this valve is more displaced towards apex. And more importantly, you can see the morphological features of this ventricle. They have a moderate band or obliterated apical area and more round shaped this ventricle, this, you know, if you see enough, you know, this is not a morphological LV. Normally, we will see aorta arising from left-sided ventricle. Again, similar to masters. Anatomically, you have a morphological RV supporting the systemic circulation. So in this group, we have associated dextrocardia or mesocardia quite a lot. Epstein anomaly of tricuspid valve may be the main cause of tricuspid valve regurgitation, slightly different from patients with mustard. And some patients will have associated VSD and pulmonary stenosis. So not difficult to understand the long-term problem is RV dysfunction, tricuspid regurgitation. And in this group, we will see more conduction problems like a complete heart block can be onset late in life. So we see that Epstein anomaly is the major cause for the tricuspid valve regurgitation in CCTGA, and it is often underdiagnosed. It is because this Epsteinoid abnormality in these settings that differ from a classical Epstein anomaly. The lack of thinning of atrialized portion of the RV very rarely have absence of mural or septal leaflet. They have a small size of right ventricle. And like this patient, we see there is a exaggerated displacement. I think that's it. This kind of, we call the Epsteinoid abnormality. We don't have large atrialized ventricular components like this, like in classic Epstein anomaly. Surely this kind of valve will develop incompetence quite early in life. In rare cases, we do see severe valve regurgitation without a structure valve abnormality. Here is one of our patients. She's in her 20s. In these kind of cases, usually TR is the consequence of ventricular dysfunction. But because of hypodynamic of regurgitation, the ventricular dysfunction will be masked by this hyperactivity. But when we look carefully, we can find what is really underlying hemodynamic abnormalities. Here, I labeled it tricuspid valve regurgitation. It's severe. The Doppler profile becomes triangular. In addition, the flow velocity is merely over 3 meters per second. Imagine patients need to have at least the blood pressure 80 to survive. So the left atrial pressure is very, very high, must be 30 and plus. And on the other side, when we look on the right side, the mitral regurgitation, it is trivial. Don't forget, its morphological LV is designed to sustain a high pressure. So they don't develop a failure earlier. They will develop failure only late in life. So you see, although it's mild, we got the flow velocity 4.5 meters. So this flow velocity reversal between systemic and pulmonary circulation. It's an omen. It's also Dr. Gibson's sign, we call, because this is what we were told by Dr. Gibson. He said, if you see this sign, you must be careful. The patient is in a hemodynamic crisis. It's really true. Further, when you look the tricuspid filling, you can see, despite in sinus rhythm, patient only have a single E wave. There is no A wave at all. So we can judge by this, the patient filling pressure is very, very high. Although these criteria not fulfill possibly the guidelines in normal biventricular heart, but we can assess by ourselves this is systemic RV. By the echo appearance, we can judge this have very high filling pressure. Indeed, this patient died actually 2 months after. Her clinical presentation only chronic cough for lasted more than 2 years. I think, Rafa, you still remember that patient. So we see heart failure in patients with systemic RV is unavoidable complications later in life. Impaired function of the systemic RV is a well-known factor associated with limited exercise capacity, heart failure symptoms, and increased mortality. But clinically and echocardiographically, it's very hard to assess the ventricular function very accurately, although all these echo parameters has been published in the literature, but we still cannot pin down one of the parameters gave us the guidance about prognosis. Here is a landmark publication by Peterson's group, and then you can see they have demonstrated using the study of longitudinal and circumferential strain imaging technique. They showed systemic RV more function like a normal LV. They have a less longitudinal strain compared with normal RV. They have increased circumferential strain compared with morphological RV in a normal setting. But they lost the twist between apical and the base. And this might be a reason these ventricles are not as efficient as a normal LV. So simple study by strain in, I think this published quite early in 2012 by our group, Gerhard Diller has lead in this study. We have found more than 80% of our patients with systemic RV have reduced global longitudinal RV strain, and more than 44% of them have impaired LV strain as well. The RV strain of -13 or less is associated with clinical adverse event. So just from this study, we know this strain does reflecting ventricular dysfunction. Maybe it's useful clinically. But sometimes you do see patients doesn't falling into the category or into the knowledge we already know. Here is a patient, 29 years old, was referred for the assessment because the patient wanted to have a pregnancy. She's completely asymptomatic and clinically functioning class function 1. She told me she runs every day and she has no limitation, go to gym every day. So to our surprise, we assessed by 2D imaging, you see the fraction area changing 8, and her global longitudinal strain is severely impaired. So I just wondered how this patient is functioning class 1. So we looked on our 3D RV assessment, EF is 35, which is reasonable. So we looked at the MRI assessment. They gave us a value of systemic RV-EF 40. So from MRI result, they are not concerned. And also patient only have minimum fibrosis. So prognosis should be very good. So we still didn't understand why there is a big discrepancy from our 2D imaging modality measurement and the 3D. So we further analyzed the heart using this new software called Revision, which was developed by Atrial from the Hungary Heart Vessel University. And we divide the right ventricle into 3 planes, longitudinal, radial, and anterior posterior component. We find in this heart, the anterior posterior component contributing most to overall ventricular ejection fraction. But this anterior posterior component, we do not see on our 2D assessment. So 3D does have an important role in accurately assessing the ventricular function in this heart. Is this also true in patients with congenitally corrected transposition? You can see this 3D image of 2 ventricles, but they have different shapes. It's very hard to pin down just using this global, the model of the 3D imaging, you see the bulging of septum into the opposite direction. So we also further analyze this kind of this heart, divided CCTGA and the TGA after mustard outstanding repair. We find that these two groups of systemic RV have different mechanisms of contraction. In patients with mustard, the anterior-posterior component is dominant, but in patients with CCTGA, the longitudinal contraction is dominant. This also, this finding consistent with earlier this strain finding in CCTGAs, their longitudinal strain more looks like in the systemic LV. They are maintained, they contract well. So although both are systemic RV, the mechanisms of main contraction, they are different. But when you see the patient every day, there are other things also inconsistent with what you imagine. Here is the two patients, both on the 2D analysis of the fraction area change of the longitudinal strain and eyeballing it. The systemic RV is severely impaired. Maybe the 3D imaging will tell us something more. But these two patients are similar age. One patient is completely asymptomatic and won't have pregnancy. The second patient, CCTGA with age 35, she's clinically in failing status. She's waiting for transplant. So what else is a contributing factor? This made us thinking. So we simply just looked at this group as a whole. We studied both LV and RV function. Here is this paper recently just come out. So very simply, from the four-chamber view, we measured both left ventricle and the right ventricular area and calculated fraction area change, and also measured the longitudinal TAPSE and MAPSE. Now we looked at correlated this ventricular function with clinical status, New York Heart Association functional class. We find both LV fraction area change and RV FAC are significantly reduced in patients with signs of heart failure. And to our surprise, the LV seems more accurate in predicting the higher NYHA functional class. I think in patients already had a failed systemic RV, in addition, you have a failed left ventricle, then the patient is really in trouble. Maybe this is really gone into the end stage. So what's the reasons for the patient with mustard or CCTGA had the left ventricular failure? Here's one of the examples. So some patients can develop severe pulmonary arterial hypertension. I said morphological LV can sustain the systemic pressure. So they will not develop a failure until very, very late stage. This patient, obviously, LV function is very, very poor. But you can see the pulmonary artery is severely dilated. And in this group, they don't develop a mitral valve regurgitation until very late stage. And this is another reason of their severe PH being missed, not diagnosed on echo. Now we have learned if you can catch the pulmonary regurgitation and look at the pulmonary flow Doppler, we can diagnose PAH earlier. You see from the early pulmonary regurgitation velocity, we know this patient had a flow velocity of 4 meters. So the mean PA pressure will be in the range of 70. Also, patients have very short acceleration time on the pulmonary Doppler, all signs of severe pulmonary hypertension. Then Another reasons of failing LV, maybe some have intrinsic left ventricular disease. Here is another patient with mustard. We find they have a clot in the morphological LV. If you think why, this is really not goes with our conventional findings. Normally, it's the RV fails, not the LV. But this patient indeed had a left ventricular dilatation, left ventricular dysfunction. You can see also have a severe TR. And when we look at the valve Doppler for the hemodynamic, we also find the mitral regurgitation velocity is higher than the tricuspid flow regurgitation velocity, with a restrictive RV failing with a mean PAP around 50. So this also have a Dr. Gibson sign, really. This is really an omen. And this patient I just checked when I was doing this presentation. 2 months after this echo, he died at home, unfortunately. We have been trying to put him on the transplant list, but the patient has refused, just run away from the hospital. So from above information, we just have to learn RV and LV shares a common fiber, septum and pericardium, so their function is affecting each other, especially in patients with systemic RV or in patients with Eisenmenger or Epstein, this kind of RV dominant disease. We shouldn't forget to look at or assess the left ventricle when we're doing echoes. So next group of complex lesion is univentricular heart. I think when we talk about univentricular heart, everybody think, oh, it is a complex group. How can patient only have one ventricle that survive? We all know the four types of atrial arrangements. They can connect to the different 3 type of ventricles through a 3 type of connection, either absent left, absent right, or double inlet. The complex thing is the connections are independent of atrial arrangement and a ventricular arrangement, and also independent of valve morphology. So that, for example, you have an absent right connection, you can still have on the left side a tricuspid valve, not mitral valve. And you can connect it to a morphological LV, but it can be a morphological RV. So it's so crucial we go from sequential segmental analysis in this group of patients. 3-dimensional echo does help us in understand the spatial relationship of the valve, ventricle, and understand the anatomy of the heart. Here is a patient on the left. Maybe looks like a cross-section view of the 2D. We showed 2 AV valve coming into the ventricle, but we can see on the left side there is a rudimentary small ventricle. But whether it's double inlet or not, maybe we have to assume this it is with over 50% of this AV valve is emptying to the ventricle, which already received another AV valve. But with 3D give us advantage. We rotated around, and here when we look from the apical towards the base of ventricle, we can see clearly this ventricle contained 2 AV valve in the main chamber. The anterior small ventricle have no AV valve into it. Aorta is really anterior, arising from the rudimentary RV, and we've got PA is really posterior, arising from LV. So if you have a 3D skills, really please do use it. When you don't understand the anatomy, you can look at the heart in more detail with the 3D imaging. I think help us to make the more accurate diagnosis. We all know that patient with a univentricular heart come to us, they all, or most of them, will have undergone the previous Fontan type of surgery, be it earlier atrial pulmonary Fontan with a huge right atrium, or TCPC with intracardiac tunnel or extracardiac tunnel. Despite they have Fontan type of operation, this is not a correction. It's a palliative surgery, help them survive, but there are a lot of complications because anatomically they still short of one ventricle. So normal biventricular hearts, they have two ventricles. It's not without reason. If you have one ventricle, then you will have a limited survival, or you will have a lot of complications even from the surgery. So when we're looking at them or checking them, we should assess all the surgical repairs, whether it works fine, whether the connections narrow or leak, especially when it's dilated right atrium and connected to the atrium. We need to check whether there is a thrombus formation in this hugely dilated atrium or not. So the Fontan type of operation is supposed to make patient pink, but as the patient getting older, we find them all to some degree sinused. There are many reasons. I think most important reason is because they have a high venous pressure with non-pulsatile systemic venous return. So there are a lot of venous malformation and communication happens, not only in the heart, but outside in the body. Then the patient end up into a desaturated. So we also think the complication with systemic ventricular outflow tract obstruction, especially in patients with double inlet and VA concordant. Again, ventricle and valve function is a very common late complication. For the Fontan connection, I have to say MRI provide the best image. They can show the whole connection very beautifully. I'm not going to compete with them, but the outflow tract obstruction, you can really accurately diagnose with echo. You see this patient have a double inlet with atrial pulmonary Fontan, obviously had a VA discordance, had aorta anterior arising from rudimentary chamber. Then there is a harsh systolic murmur with a peak systolic flow of 6 meters across the VSD. So this VSD is restrictive. Hemodynamically, this is equivalent to subaortic stenosis. So this is very important lesion. We must remember Fontan circulation is supposed to be a silent circulation. So any murmur, any turbulent flow is abnormal. We must check. And one of our patients, we recently reported 3 of them. One of them actually they mislabeled as PS, pulmonary stenosis. She has died suddenly when while waiting for surgery during a coughing attack. So this is important hemodynamic lesions. We should be careful and assess them carefully. The other different complication, I think not well known, or we haven't seen many, is this patient with VA discordance after Desmond's K repair. Surgeon had made AP window in keeping both pulmonary and aortic valve open to the aorta. To our surprise, one patient come to follow up. She had severe native pulmonary valve regurgitation. And then to our surprise, I think CT scan showed this huge aneurysm formation at the opposite of anastomosis site. So it's kind of a rare complication. Echo may miss it, but other image modality is very useful. AV valve regurgitation can be functional, like this patient, The valve structure seems nothing wrong, but you can see the annulus is really dilated with absent left AV connection. And also the regurgitation is very long, filling time very short. This is prolonged systolic duration is a sign of ventricular dysfunction, and the patient has significant regurgitation. Here's another patient. You see clearly the valve is prolapsing, and this patient's ventricular function is much better than the previous one by judging of systolic duration is still shorter than the diastolic duration. So ventricular function, again, is very important in keeping the Fontan circulation. And it's difficult for us to accurately assess them, especially ventricular diastolic dysfunction in the univentricular heart, because their anatomy is very diverse. We can have morphological left, or we can have morphological right. Now we can have sometimes it is a sort of biventricular heart, but with very large defect. So what is the normal value? Even we can measure the EF, we don't know. So we can see this is the morphological RV. They have so much trabeculations, even trace the subendocardium border can give a discrepancy between different operators. But this patient may be eyeballing it, we see this ventricular function is impaired. And when we look at the filling time, much shorter, with systolic to we see normally should be less than 1. So surely this is reflecting severe ventricular dysfunction. So when Rachel Cordino was with us, she has looked at the Fontan circulation patient in all of our Fontan patients, and assessed with all the parameters available for systolic and diastolic function. Finally, what she finds is this trans-AV valve Doppler measured systolic diastolic ratio together with NYHA functional class. We can differentiate patient survival. So you can see if you have a NYHA function class 3 and 4 plus with SD ratio more than 1.1 at 8 years, the survival rate is less than 75% compared with the opposite of patient to survive will be 95%. So it's very simple parameter, but is useful, give useful prognostic value. And further on, we want to know what's the meaning of this systolic diastolic ratio. We compared with the CAS data, we find they have very good correlation with the diastolic pressure of the ventricle. The sensitivity is 100%. So when we assess Fontan patients, don't forget using the systolic diastolic ratio to assess the ventricular function. So this is my talk. In summary, I will say when assessing patients with complex lesions, we must follow the sequential segmental analysis. It can make the complex malformations simpler. So advanced echo techniques, the 3D SPECT tracking, is really very useful in assessing the congenital heart disease. It helps understand the anatomical abnormalities and also help us in accurately assess the ventricular function, which is crucial in assessing and follow up this group of patients. We should implement in our routine clinical practice. Thank you very much. Sorry, I'm a bit delayed.
No, you're okay. On time, perfect. We have 5 minutes for discussion. Thank you, Wei, for this great talk. So if you want to ask any questions, either write them on the chat or you can unmute your microphones and ask the questions. So while you were talking, a couple of questions came through. So one question is, in patients with CCTGA, do you see a failure of the lamination of the tricuspid valve in echo? So basically, how often do you see an Epstein-like valve in CCTGAs?
I think, we are under-labeled for Epstein because there is no criteria for it. We can't use like all the full criteria to diagnose this. I think if we can see a marked displacement, we should diagnose them. Possibly at least 30 to 40% of them will have marked displacement or displacement more than normal. The offsetting, I mean.
So there's another question from George Yanakoulas that you know very well. So he congratulated you for the talk, and he said, how do you assess LV function in patients with tetrayophallote or repair pulmonary atresia with VSD that they have a very prominent paradoxical septal motion? Did you use the LV ejection fraction? Did you use strain? Did you use MAPSE? What did you use in patients in this setting?
Yeah, we use everything. We use everything. Still not get it right. That is the limitation of our practice, isn't it?
Yeah.
We are trying best. We are trying our best. But I have to say, because the VSD and reverse septal motion makes the EF difficult to assess. So the strain speckle tracking maybe can give you a better value. But for me, overall hemodynamics, we have to look at the flow. Now we learned with patient with ischemia, with patient with pulmonary hypertension and univentricular heart. For me, now I will tend to use more and more this systolic to diastolic ratio of trans-AV valve. Although in this lesion, we haven't learned their prognostic values, but I think this is very useful marker of ventricular dysfunction. It's very sensitive.
I agree. So there's another question for Ken. Ken is one of our previous fellows from Japan, and he said, "Thank you for the great talk. And how do you assess diastolic function in complex congenital heart disease?" Because that's a tricky.
That is my next PhD, maybe. Yes, I know that diastolic dysfunction is very, very common in our patients, especially old patients. I think, and also they die from the diastolic dysfunction. It's not often the systolic dysfunction. But we cannot pin down to say very accurately based on echo. I would say this patient had a filling pressure more than 15 millimeter mercury. It's very, very hard. We are driven by guidelines, although there is a beautifully written guidelines on how do you diagnose diastolic dysfunction of the LV. Often we find these criteria don't apply in our patients because I often use it. I said, okay, so in our patient with EE prime, is this apply? Obviously not apply if patient have a septal surgery, VSD. Then the septal E prime is very low. You can't see this in normal, this patient have diastolic dysfunction. Actually they didn't. But in another way, they do have severe diastolic dysfunction. Their lateral wall E prime can be very, very high. I think this diastolic dysfunction criteria is only a ratio. I don't know why they have to go with diastolic dysfunction. It's only a correlation maybe studied. But intrinsic myocardium dysfunction, we really have to assess them not only with the velocities of myocardium, we should look at overall whole picture of the heart. If the patient comes had a dilated atrium, higher PA pressure, dilated vein with less collapsing, without reason for right heart dysfunction, then you can easily say this has diastolic dysfunction. So for details, I think we need to really learn from our patients. We should maybe multi-center studies to collect our data to create our criteria for this group of patients.
So MC has a important question following the previous question with NCCTGAs, that in patients with the definition of an F-stenoid tricuspid valve is pretty vague. So because there is no really deviation of the tricuspid valve hinge point away from the AV junction, and should we still label it as F-stenoid based on the AV valve offsetting, or what is the criteria we should use to define an F-stenoid valve in the setting of CCT?
I think offsetting is good. For me, it's good to look at the coapting point, to look at the regurgitation where it's originated. If regurgitation is started in the middle of the ventricle, you know the coaptation point is quite low, then it's more likely go with the Epstein type abnormalities. I know there is no clear cut to see which type is Epstein. If you have patients with regurgitant valve with a low coapting point, I would think this is more likely to have element of Epstein abnormalities.
So, just one question from me. So how often do you use the RV strain in your systemic RVs? Is that something that you do regularly or just use it in occasional? No.
I think, Rafa, since you left, we have improved a lot. Now we have OG machines for the congenital team. We got 3D machines. And since Elena had brought us a technique of 3D, she had trained all our technicians, our groups to acquire strains and 3Ds. I think whenever possible, they all acquired. Now, I think it is very useful now. All this new advanced technique, it's what more you use, is more value you get from them.
Mm-hmm. I agree. So, Erwin, do you have a comment? Or?
Yeah, thank you very much, Wei, for this fantastic talk and teaching us some pitfalls and tricks how to assess the ventricles in these patients with complex congenital heart disease. I fully agree with you regarding assessment of the diastolic dysfunction. All these guidelines and algorithms only apply to patients with biventricular physiology, and actually there are patients for acquired heart disease, but they do not apply to patients with univentricular heart and Fontan circulation. And per definition, all patients with congenital heart disease do have a diastolic dysfunction, so to begin with, and probably underestimate the severity of diastolic dysfunction. These patients, we only focus on systolic function. I have a question to you. So actually you answered already the question. So that's routine now in your lab to do advanced echo techniques to assess systolic function in patients with congenital heart disease, like strain, longitudinal strain, circumferential strain. Number two, do you have specially trained sonographers who are scanning congenital heart disease patients in your lab?
Yes, thank you. Thanks for your comment. You know, I totally agree with you. What we're facing is the same problem. So for the using of advanced echo, yes, I have to say we are getting better. We have encouraged them to apply advanced echo technique in every single patient unless the imaging quality are not sufficient enough to perform 3D or strain. For strain, usually it's very easy. You don't need particularly very good pictures quality. But for 3D, especially on RV, is limited by 2D image quality. So we still have a lot of them. There is not sufficient a 2D image to perform 3D, but basically our principle is to apply this in every single patient. Second question is our sonographers. I think after many, many years of fighting, Rafa may know, we all started just only me and one. Now I'm very pleased to say I do have a team of very well-trained sonographer. And most of them is only do CHD. They don't do general scan. There is two. I have 5 of them. Two of them attend stress echo for general cardiology, but 3 of them purely CHD. They scan congenital heart disease all. But before they come on board to do congenital, they have to be trained in general echo. That is basic route they go. They trained sufficiently in doing the general echo, then they can further develop into congenital echo. They usually will take accreditation and also trained in our team by the senior sonographer. And at this time, I do also have 2 senior fellows. So these fellows also attend the transthoracic echo and also attend the intraoperative intra-procedure TOE with me. So our teams are getting better. Still not enough. We need to train more. Thank you.
I think that's the only way you can maintain and sustain high quality service in echocardiography for CHD patients. As you said, the training, it's on top. It's like for the physicians. You do a general cardiology training and then CHD, that's a specialty training on top. And this also applies for the images and the sonographers. So you need to have a very solid, robust basic training in general echocardiography for acquired heart disease, and then you need to have an on-top training in congenital heart disease to provide excellent images and imaging service to the congenital heart disease patients.
Okay, so I cannot agree more. So after training, I trained in that lab. Wei trained me, and have to say that that most of my training came from Wei, but also from the sonographers. So had two of the sonographers of the 5 that are working for her now. One of them trained me, Caroline, and I think that was one of the best experience that I had. And I think it's extremely important that your sonographers know the anatomy of the complex. If you don't know the complexity, you cannot really get all these advanced images that I think we need to move towards in the congenital heart disease field. So Wei, thank you very, very much. It's been a great pleasure to have you here. And it's been great to see you after 2 years. We haven't seen you since I left. And thank you for agreeing to give this talk. It's been an amazing talk and very, very thoughtful and with a lot of teaching points. Thank you very much, Wei.
Thank you. Thank you.
And for that attendees, thank you for joining us today. And good morning, good afternoon, or good evening, wherever you are in the world. Thank you, Wei, and see you around. Bye-bye. Hopefully I see you in person, if not this year, next year for sure.
Sure. Okay. We will meet one day.
Say hello to the team. Say hello to the team from me. Bye-bye.
Thank you. Bye-bye. Take care. Bye.